Hello, everyone, and welcome. Well, I just want to say thank you to everyone for joining us. I am Dr. Wendy Leonard. I'm the founder and executive director of TIP Global Health. We're a global health organization based in Rwanda, where our transformational approach to collaborating with frontline health workers, aligning with national government priorities, and utilizing data to inspire and inform is achieving lasting improvements in health outcomes. So I really want to thank all of you for taking the time to join us today and learn about our approach to hope in healthcare. We have an amazing lineup of speakers and panelists today. And before we begin, I just have a couple quick housekeeping points. The first is to please submit any questions you might have in the Q&A section. Our panel moderator will keep track of those questions, and we will save those questions to the end after all of the panelists have spoken. Also, the event is being recorded, and so we will share out a recording of the event once about a week after the event has completed via email. So with that, I'm going to share my screen and provide some background into how we came about this concept of hope in primary care and healthcare. So primary care is really considered the opportunity through universal health coverage and primary healthcare delivery to achieve sustainable development goals. But what is primary healthcare? It's not about a condition, it's actually about an approach. And that approach is thinking about prevention of a disease before it's happened, early diagnosis when it does happen, early treatment, and continuity of care to prevent any secondary complications. So how does that happen? What is the most effective way to consider primary care? Well, a community member needs to access care. She needs to receive quality care that leads to her going home and adopting care recommendations and sustaining those care recommendations, and then coming back for more care. And it's this virtual cycle of accessing, adopting care recommendations that drives primary care. So what drives this virtual cycle? Relationships. Specifically, the relationship between a frontline health worker and the community member that she is serving. Unfortunately, local healthcare delivery systems around the globe too often look like this. We know that the frontline health worker community member relationship is the cornerstone of successful primary care, but unfortunately local health systems are not designed to support this relationship, and competing priorities often strain the relationship beyond effectiveness, leaving both parties, the frontline health worker and the community member she serves, feeling disconnected, powerless, and exhausted. Instead, a local healthcare delivery system can look like this. When we focus on eliminating the barriers to providing and receiving care and creating space for this relationship to thrive, that's when primary care can be the most effective. And we believe at TIP that these relationships need to be equitable and that both parties should feel valued, capable, and hopeful in the future to be as effective as possible. So TIP Global Health has been working in Rwanda since 2008, but specifically in 2013, we worked with 9 health centers to address their community goals of decreasing mother-to-child HIV transmission and decreasing malnutrition rates amongst HIV-exposed infants. We worked together to identify the definition of quality care, and we came up with 5 pillars: clinical skills, mother-centeredness, health education, data management, and logistics. We identified criteria for each of those pillars, and then we cross-checked that with the national policies to make sure that everything was consistent and then also replicable. We conducted an observational checklist, and we found that those scores at baseline were 39% when we aggregated everything together. But rather than starting with that low number, we pulled out the numbers where people did really well. And they did really well with mother-centeredness. So we brought all of the healthcare workers back together. We presented the data, we celebrated their successes around mother-centeredness, and then we brainstormed together opportunities to improve their system of care slowly but surely. And then we continued this cycle, and you can see that the quality of care continually improved over time. But in 2018, we saw a decrease in quality, and that was related to funding cuts, decreased staffing, and decreased morale. So at that point, we introduced a new approach, which was to give each health center their own unique data and encourage them to go back to their health centers, engage the mothers that they were providing care for in the problem-solving process, identify improvement projects, and then come back every 4 months to share those results. And since that time, we've seen skyrocketing improvement in quality of care, and consistently has stayed above 95% ever since. What has been particularly exciting about this is that the community has been able to virtually eliminate mother-to-child HIV transmission and dramatically improve rates of childhood malnutrition amongst HIV-exposed infants. And what we really found was that by providing opportunities to see early and quick wins through tracking data around processes, we were able to help them see how they could get to the longer term goal of improved health outcomes. And another part of this that was very interesting was that we introduced in 2015 this concept of the diffusion of new ideas, which is demonstrating basically someone's comfort level with change. And we asked the healthcare workers we were working with, where do they fall on this innovation spectrum? And we found that the vast majority of nurses were early majority, and we had a couple of late majority and skeptics. We had no innovators or visionaries. But in 2018, after we had seen dramatic improvement in quality and health outcomes, we also saw this really exciting shift in mentality, where people were now their own leaders, their own problem solvers, and change makers within their communities. And so this is what really got us excited about the idea of how hopefulness and utilizing data to inspire, inform, can inspire innovation as well. So this early work has inspired everything that we do today. Whether we are designing a point of care digital tool for frontline health workers, or we're preparing a presentation or a training, we always think about how to utilize data to inspire hope and provide a pathway for improvement. We're now conducting rigorous research to prove that the concepts of hope are critical to effective primary care delivery. It's now my great honor and pleasure to introduce you to Angèle Bienvenue Ishimwe. Angèle is the Director of Behavior Change for TIP Global Health, and she's the principal investigator for all of our HOPE research. She oversees all aspects of research related to hopefulness and resilience in the healthcare systems, and she will now give us an overview of her critical work.
Thank you, Wendy, for this profound introduction. In TIP Global Health, we have HOPE initiative, and we are really dedicated to demonstrate through researches the impact of hope to improve health outcome. We are doing so, we started it by defining hope as the desire for and a belief in a positive future. But we also have objectives and goals through this HOPE initiative, and we have a sequence of researches to demonstrate how hope could improve the health outcome. Next, please. what we did first in these sequences of researches, we first established an objective tool to evaluate how hope is improving the health outcome or how hope is changing. This was the first research that we conducted. The second research and the second phase and the current research is to understand the influences of hope by using our objective or significant factors regarding hope. This phase is to allow us or to educate about what is influencing hope and how we can utilize those influences and the gaps to design the evidence-based interventions that can improve hopefulness and improve the health outcome, which will be also our third phase of implementing interventions that can increase hopefulness. Next, please. What we did first was to design an objective tool, as I was saying. And what we realized there was no tool in Rwanda that could evaluate hope. So we took a tool that was initially developed in the US 2 decades ago, the Heart Hope Index, and we transculturally translated it in our local language, Kinyarwanda, and we used our culture and our understanding to be able to have a tool, questions that we can understand and respond to them easily. After that, we conducted focus groups to make sure that our stakeholders in our context, frontline healthcare workers and mothers, can utilize that tool easily and be able to respond to the question without any difficulties. After that, what we did was to validate a questionnaire that we had, the questions that we had. What we validated was first, internal consistency of questions. If the responses that were given are consistent, and the statistics, it shows that our tool, the final tool, showing the internal consistency of responses. The second thing that we validated was the reliability of responses within time. So we conducted 2 surveys within 1 week in difference, and we found out hope score is not changing a lot when someone didn't have any big incident in that period. Last but not least was to see the factor structure of our tool. Initially, the tool had its factor structure. There were 3, and we wanted to measure if the tool that we are having has the same factor structure. If not, we're going to identify other factors that are related to hope and that can define hope the way we want Rwandans in our culture to define hope. Luckily, we found out that they have the same properties found. They have the same factors, which are interconnectedness, future mindset, and readiness for change. So this was our first step to go. And we used these factors for the future, because this is how we are going to define hope for our future researches and future interventions. Allow me to present the first example of the first question that we had. The first question was, I have a positive outlook toward life. As you can see, this is a question designed as a self-administered survey. What we did is to have a question in a second person, where a person will be taking an interview rather than filling a questionnaire. The question changed to, do you believe that your life will be better in the future? And we changed also the response option, where initially it was a scale from strongly disagree to strongly agree, and we couldn't find any vocabulary or any words that were going with these words, and in a way that we could understand that. So we changed it to visuals, and we were asking individuals to compare their feeling or their understanding with the way, as you can see, the cups are filled at a different level. The level of their feeling or their hope or their agreement with the statement, they can choose the one cup that best fits their answer. So we did this work 2 years ago, and we have been able to publish it in BMC Court of Life outcome. Our second phase was to identifying influencers of hope. And with the way we did that, as we have been able to identify factors that can define hope in three factors: interconnectedness, readiness for change, and future mindset. These guide us to be able to provide, to understand, to provide interview guides that we are going to use for a qualitative research that we are conducting now. This is a current phase, and we conducted interviews to over 70 frontline healthcare workers, over 100 mothers, and we also asked the researchers, policymakers, and managers be able to understand well their perspective around hope, more specifically around those three factors. That is how we are defining hope. After doing that, we collected our recordings, we did the transcription and then translation, and we sat together to see what are the most common codes that we were found. And after that, we went through our transcript to read them and see what are more sequences or information that we are facing or we are seeing more often related to our factors. What we have seen is that relationship is really driving hopefulness. As this mother saying, when a health worker gives you advice and she sees that you are adopting them, it makes her happy and it gives her hope that what she does is important. This mother, what she's saying, if we see it in a perspective of a frontline healthcare worker, what we see is that this nurse is aware that it is important to have a relationship with the mother, with a care receiver. And she has this ability, but she needs also to get recognized, to get, so that she knows that what she's doing will have an impact in the community. And also she needs to have the support from the system. She needs also to have the tools or the time that she needs to be able to build this relationship. The same for the mothers. The mothers are also aware that it's important to build the relationship with their care providers. They know that it is important for them so that they can have all the information they need so that they can get all the treatment they need. But sometimes they have found a barrier at the first entrance. The first impression they have when they get there, sometimes it is not welcoming. Or when it is welcoming, the court of care is not allowing them all the time, is not allowing them. Or even the system is not allowing them because they don't know that it is their right to build a relationship with their mothers. And this sometimes it threatens them to change, to be able to adopt new changes because they didn't build this relationship or trust with their care providers earlier. When we go to the readiness for change, also our mother here is saying, training is needed because when we came here to the hospital and they advise us while explaining why, that makes a person be open-minded and find a way to develop herself. If we see this as a healthcare worker, we have also, as a healthcare worker, we can see there's awareness. Next, please. Frontline healthcare workers can also experience some challenges and facilitators during their way of changing. Their awareness and ability about the change influence a lot about the way they will adopt the change. As long as if they know that the change will lead to a positive health outcome and they have been advised or informed earlier in a good way, it also influences their way of changing. As long as also the health system is providing all the necessary tools, this also increases the ability of a health worker to adopt the change. This is also the same for pregnant mothers and also breastfeeding mothers, the awareness about the change. Sometimes they get offense when someone is telling them to change something and they don't know why. They might resist, but not only because they don't want to change, just because they don't know why they have to change. The same, they need also to understand why they are changing and how they need to change, and the support they need to change, whether they have to be the same, the ones to create the support they need or to create those innovations to change, or they need a support or motivation from the system so that they can change. Yeah, this is what we were reading. We have been reading around readiness for change from interviews that you have been conducting. Next, for future mindset. For the future mindset, we are still gathering the information. We are still reading to understand more about what healthcare workers and what mothers are saying about future mindset. But what I can share, if we believe that tomorrow will be better, we can bear a hardship today. I think that's what is driving us. That's why we are here. We want to have a brighter future, and we want to build it right now. And we believe that the future is bright. So our next phase, after when we finish this analysis and the information that we have here will give us information to be able to design evidence-based interventions. And those evidence-based interventions will allow us to design a program that is optimizing hopefulness. What we'll do is to provide a threefold intervention that will tackle individual, interpersonal, and health systems level. And the way we will do this will be also another research after the current research, and it will be randomized control trial, and it will allow us to see to improve the quality of care while improving hope, and also improving the engagement to care, and most importantly, allow us to improve the health outcome. If we can say for our current intervention would be to improve the maternal child health outcome. Thank you. I'm also honored to introduce today's moderator, Linda Villalosa. Linda is a contributing writer for the New York Times Magazine, where she covers race, inequality, and health. Her articles span topics from the crisis facing Black mothers and babies to the toll COVID-19 has taken on Black communities, to medical myth, life expectancy in Chicago, and in the environmental justice movement in Philadelphia. Mrs. Villalosa is the author or co-author of 3 books, including Body and Soul, The Black Woman's Guide to Physical Health and Emotional Well-Being, Under Her Skin, Racism, Inequality, and the Health of a Nation will be published by Doubleday in June. She's a journalist in residence and associate professor at the Craig Newmark Graduate School of Journalism and the City University of New York. Welcome, Ms. Villalosa.
Thank you. Thank you, Angel. Thank you so much. And I really enjoyed your presentation and learned from it. Thank you, Wendy, for being the driving force behind this. I'm honored to be here because I am a journalist in the public health space. So that means there are 2 places that are where we don't focus on hopefulness. Journalism is about conflict, and it's about, the worst case scenario and showing that. And public health is often about problems. So it's wonderful for me to be in this space where we're not just looking at a problem, we're not just working on ways to solve a problem, but we're working on ways to solve a problem with something that we all have in our power, which is hope. So for the next 20 minutes, Angel will discuss with Dr. Opara, who I'm going to introduce shortly, Ijeoma Opara, talk about ways that we can put hope in action. So we'll speak for about 20 minutes. I'll ask each of our panelists a couple of questions. And at the end of the entire session, there will be a chance to come back together where you can be involved as well. So let me introduce Dr. Opara first. She is clearly she's a physician. There she is, right in her scrubs. Dr. Opara is a double board certified assistant professor of internal medicine and pediatrics at Wayne State University School of Medicine, associate program director of the internal medicine pediatrics residency, and attending physician with Wayne State University Physician Group in Detroit, Michigan. Now, this is the part that's super interesting and super important. She is the founding director of an innovative initiative and curriculum, Health, Equity, and Justice in Medicine. So in this initiative, she's working with internal medicine and internal medicine pediatrics and pediatrics residents to create the healthcare providers of the future by teaching them critical reflection, community engagement, scholarship, and also to not just look at the doctoring part of medical school, but to look at the part where healthcare providers should address social and structural determinants of health and health disparities. And so that is very important as we move to a future where we're acknowledging what we've long known. So thank you both for being here. I'm going to start with Dr. Opara and ask a couple of questions, then we'll move to Angel. What is different and wonderful about the program that we're talking about is we're taking an initiative that, happened not here, and bringing it here to solve some of the problems that we have in the United States that are similar to some of the issues that happen in countries, in African countries. And we're, for a change, saying, hey, something that works there may work here as well. So Dr. Opara, since you've seen both places, can you talk about that exchange of ideas and how that worked and how you saw that?
Thank you so much, Linda, and thank you to Angel, Wendy, Tip, Boma Global, and my fellow panelists and all the audience members out there in Zoom land. Thank you for this space. I'm really glad to come to you from Wayne State University, Detroit, from my office. I just finished rounding in the hospital. And so to your question, Linda, around how did we see this exchange of ideas? As you well know, global health and the field of global health and oftentimes the dynamics governing the international relationships between the US and abroad are steeped in colonial dynamics, right? They're steeped in colonial history, colonial context, where it's always seems to be one way, where solutions are developed here and then transported over, regardless of the context, regardless of dynamics, history, all of those pieces, and then presumed to work or expected to work or what have you. And so what was interesting about this relationship is to look at it the other way around, to say, wait a minute, as you said, there are solutions that are working in the different contexts that maybe we can learn from in a conscious way, because I believe that we're always learning and extracting lessons. Again, that's the spirit of colonialism and gems elsewhere, and bringing them here and developing, the US and Europe at the cost of other folks that live elsewhere. That's always happening, but this was a conscious way in which, credit is given where credit is due, as to how we can solve problems of hopefulness, resilience among healthcare workers and healthcare recipients, especially in the field of maternal health. And that is one of the things that really attracted me to this. It also attracted me because as a woman of African descent myself, I was born and raised in Nigeria and identify as a Black woman and a woman of the African diaspora. I see the interconnectivity in history and the socio-cultural dynamics throughout the diaspora, understanding that what happened in Rwanda had some parallels to the things that we're experiencing here in the US, especially as Black people, and in a city like Detroit that is predominantly African American. And understanding that some of those solutions, it will be interesting to see how those solutions developed by people of African descent, how that will also run parallel to the solutions that we're working on here within the context of the city of Detroit. So I think those pieces were key, and something that Wendy said earlier, which is tips focus on equitable relationships. I think that is the equity there. So I appreciate that, not just problems, as you said, Linda, but solutions and approach to solving problems as well, rooted in hopefulness, that can lie anywhere, especially amongst the people that usually are framed as occupying a space where they should be in a position to always receive help, but that no, actually they can be generators and producers of solutions, of knowledge, of tools, of the equipment to solve very difficult, complex problems that we're still grappling with here in the United States, and particularly here in the city of Detroit. So I'll stop there just in terms of like sort of high level overview of some of the dynamics that we're playing or that are playing inside of this partnership. And then as we continue conversing, we can sort of drill down to more specifics.
Thank you. So was there, you know, as those of us who are listening to you, those of us in the audience, were thinking, how can we do this ourselves? Or how can we, use these principles in our own work and practice? So can you talk about potential barriers to this, or something maybe even specific you saw? And it doesn't have to be like super negative. And maybe you don't want to talk about barriers. You want to talk about the best thing that happened. So either one or both.
Great question, Linda. Thank you for that. So one of the approaches that I take anyway in my work, and I practice liberation medicine, I call it, which is medicine and health that is rooted in the sociocultural and historical and political context of people who are usually, who are of an oppressed demographic in a particular community. And for us, it's usually folks of African descent. And so one of the things that I think that really spoke to that approach, and is that for us to truly operate from a place of liberation, we have to highlight strengths and assets. Oftentimes, Black folks, especially, and Indigenous folks and people of color, we are usually painted in a deficit-based, light. As you said, whether it's journalism in the media, whether it's in health, public health, healthcare, in academia, we're often the ones suffering disparities. We're often the ones suffering health disparities, wealth disparities, opportunity disparities, painted with the brush of deficit, of lack, of poverty, of disease, etc. These are and it's not unintentional. It's part of a system of design that is a system that's designed to reinforce, the dehumanization of marginalized folks in order to continue a system of exploitation. So it's not without intention. So for those of us that do work in equity, justice, and anti-oppression spaces, we are deliberate in ensuring that we are using language and therefore developing tools of assets and strengths, of resources, of capital that is housed within these our communities. And so that's why, again, that's the power of the subject of hope. And if there are folks that have I don't know any more hopeful folks than Black folks all over the world. And certainly here in the city of Detroit, we are a city of hope, for sure. City of Detroit is a city of hope. City of Detroit is a city of resilience. And, we take a hit, kicking, we keep on, ticking, so to speak. And there's some parallel with that and folks in Rwanda, and the ways in which there is a determination to determine their own destiny, seek their own solutions, and do it their own way. And that is very, very familiar here in the city of Detroit. We're folks that no matter what's going on around, we will sit down and figure out, Grace Lee Buggs calls it a quiet revolution of self-determination. How do we solve our problems? How do we reimagine, our health, our foodways, agriculture, reimagine, our education, criminal justice in a way that centers restorative justice and lifts up citizens to be the answers to their own problems. That is a constant conversation all over the city, and a similar energy is found in my experience. And I only visited once, but I've built, I believe, I hope, strong relationships where I've seen a similar energy there. So I think it's so important to lift that, where what is the capital? What are the things that both healthcare workers, healthcare recipients, citizens and professionals bring to the space as, what are the assets that they bring to space, and then how do we leverage them to then solve the problems? I will say one barrier is, and I think that's a barrier we're all very familiar with, which is, there are multiple, but the one I'll lift up is, again, investing in these community-led, community-driven, innovative initiatives to answer problems, and to solve problems. That is certainly a barrier. Really curating and advocating for robust investments in these solutions, and also the barrier of the status quo. The systems as they currently stand are not hopeful, unfortunately, in their design. And so that culture and norm needs to be disrupted in order to see a transformation of the way that things are in the current state of healthcare, public health here in the US, and certainly in the city of Detroit. And how do you reimagine and create a community-driven approach that is built in, amongst other things, hopefulness? That is a new, and for some people radical, it shouldn't be, but radical idea that requires a lot of shifting to be done, and really does need a lot of investment of resources, which are still an ongoing challenge. So that would be a challenge I will lift up. But even in that challenge, there is hope, because we are seeing examples of people that are making a difference, people coming together and moving the needle, regardless. And so there is still hope even inside of the challenge, Linda.
Thank you. I'm from now on going to call myself a liberation journalist. So thank you for that.
You are. You are, if I ever did see one. Yes, Linda.
Angel, I'd like to ask you one sort of question that is kind of both broad and deep. And that is, you've been doing this work for a while, and, you're steeped in it. So what is the thing that most surprised you, and how did you shift in your thinking, given what you learned?
Thank you, Linda. Thank you, Ijoma, for this discussion. It is really getting interesting. For when I started this research specifically and conducting interviews, because that's when I started to discuss more with frontline healthcare workers and with mothers, and see how they are really hopeful and how they want to be invested in what everything that is being done for them. Something that surprised me, and something I found that I didn't know, is how being recognized and being valued is something that you most of the time forget, but something that does many things in a mind of someone, in a behavioral mentality of someone, especially if I can say a mother who has a child. If you start by saying, I really know what you're doing is good, although your child is sick, or although your child is facing these challenges, let's start from there. But start by giving a mother, recognizing the effort that she's making, rather than starting with saying, oh, you didn't do this, you never do this, you will never be able to do this. So that little thing of recognition that you're providing to a mother, first, it creates a trust between a health worker and a mother. It also creates a an openness where a mother can say that I can talk to this person because even though I didn't do this, but she understands my life. She gets, she knows where I live. She knows the challenges I'm facing, and she knows what I can do to overcome those things. She knows the support I can get, and she knows my capacity to be able to found myself something that I can do for my baby or for myself. So that's the recognition. The same for frontline health workers. As Dr. Opara was saying, for us, different to the city of Detroit, when a new innovation is coming, we pretend or we want to start using that innovation or something new right away without knowing why are we losing what we're using and adopting this new. But that in another way, when we don't know, when frontline health workers doesn't know what she's doing and why a new innovation is brought to her, it is hard to build a relationship, to change, or even to think in the future, or to see what next will come, because she's being driven or being educated to the present only, not looking in the past, not see what is happening in the present, and see at being engaged to what will happen in the future. So what I realized is that thing of being recognized, recognizing the effort of someone, recognized something that has been done during those most challenging moments when a nurse has been able to go in the delivering room and be able to deliver, to help a pregnant woman deliver without electrical light. When you are bringing the light, first recognize that she has been able to do that, and then allow her to be engaged in that new technology that is coming, so that she's happy to embrace that without bringing that in and saying you were doing nothing before. So that is something I've learned, and that is something we can utilize, as also Dr. Wendy was saying, when we see adoption of new innovations, how the people have shifted. When we show them that they are capable, they shifted from later majority to visionaries, because they have seen that it is possible. They have been in the system being shown that it is they are able to innovate something, maybe little, because of the resources, because of the support from the system, maybe, which is not enough, but they can even innovate that little thing, that little innovation in their work, in their community, and make an impact. So thank you, that's what I could share.
Thank you for that. I love concrete things. And so both of you have offered two really, concrete thoughts. And so I appreciate that. We are going to shift to our next part of this session. So thank you both. I know you're not really going anywhere, but I'm going to shift from action to systems. So we'll talk about, how to incorporate sort of these ideas of hopefulness into actual systems. So, this part will discuss putting hopefulness in action and how it can work both sort of broadly and in depth. So for this part, we have two more wonderful women, and I will introduce them, and then we will continue our discussion about hope in systems. Dr. Elizabeth Walla works closely with physicians in Kenya to address high rates of burnout and physician suicides. She is a strong mental health advocate for all frontline workers who can provide background into the challenges being faced and describe some of the solutions. The other Linda, as I call her, Linda Goler-Blount, is deeply passionate about equitable improvements in health outcomes. I'm just gonna, from a personal note, she is the president and CEO of the Black Women's Health Imperative, which I have worked extremely closely with in my own career, and is, just a really wonderful organization in the United States that does important work. So now, hold on, I'm going to give you the real introduction. That was just my personal thing. Dr. Walla is currently the Global Advisor, Health and Nutrition in Aga Khan Foundation in Kenya, where she provides leadership and operations management to steer growth of the program. She is a visionary health manager providing strategic project management expertise in humanitarian and corporate sectors across Africa. She has more than 15 years experience spanning the fields of the health system strengthening, healthcare policies, pharmaceutical medicine, and clinical outreach. She has a very long bio, so I'm just going to shorten it a bit. There's so much fabulousness here. But what I am really impressed with is she has participated in the development of key national and international policies and guidelines, and adopted a medical affairs policy across 36 African countries. So that's what I hear, is her expertise is in high demand across the continent. My other Linda joined the Black Women's Health Imperative as the president and chief CEO in February 2014. In that role, she oversees strategic direction for the imperative and is responsible for moving the organization forward in its mission to achieve health equity, as well as reproductive justice for Black women. Before that, she served as the vice president for programmatic impact for the United Way of Atlanta. So she has a lot of experience, more than 25 years. But what I like about her experience is that she's trained as an epidemiologist. And so that is important, no matter what you're doing, and just brings an extra little piece of icing onto the wonderful cake. So thank you both for being here. Yeah, yay. So this will go the same way. I will start with Dr. Walla and ask a couple of questions specifically to sort of systems. And then Linda, same with you. So Dr. Walla, what role do systems play in influencing hopefulness and hopelessness? Well, I mean, actually influencing hopelessness in the current systems among healthcare workers. And so as context, we know that healthcare workers are burned out all over the world. And so how does hopelessness make things worse?
Thank you very much, Linda. Allow me to also say that I'm a strong advocate for health workers' rights. And I want to just read an excerpt of one of the doctors that we lost in December last year from COVID. He was a young doctor. He'd been sent to the Frontline, which means many of the casualty hospitals. And at that time, we had a lot of issues with the government not giving them proper PPEs. So this was his last message in a WhatsApp group before he passed on. He said, "My dear colleagues, let me take this opportunity to admonish you today to get your pay or get out while you can with your health or life intact. I have had the COVID virus for 5 days tonight, and I will say not even a full pocket can replenish what has been lost on high oxygen floors, all manner of masks, and begging for one more gasp of fresh air. Usually I'd write and write, but today I just want to say, save your miserable selves from these institutions. You live to earn again. I'm not in any way inviting arguments or response to my post. I'm too weak to type anymore. Save yourselves." So this was in memory of Dr. Stephen Mogusu. And this is just an example of what our colleagues are going through in a broken health system. So we are having people who are trained, whether it's nursing or medicine or with dentistry, and then released, quote unquote, to the public to offer services. But then they meet a system that is broken in all manners, right from the number of health workers who are there or the type of skills they have, going towards the infrastructure that's available. You've heard from the study in Rwanda how people improvise a lot, and we've seen a lot of improvisation with health workers. We've seen very little money or funding going into the health system, and so this affects the kind of services that are offered and the quality of services. Basically, I can go on and on. So when we talk about hope for health workers, I think we need to understand that health workers are, first of all, human beings, that the same kind of stresses that they face, that we face as the lay population, is the same that health workers face. But in addition, they have the pressure from work. They have the pressure of working in environments that are not conducive at all. And so it is up to many of us to, provide the hope that they're seeking by pulling our heads together, by putting pressure to various stakeholders who are responsible towards making these environments better, in order to at least tell them that, look, you're not alone. You are not like this young doctor who wrote his last message when he's very, very broken, and that there's action, there's activity, that it's not just lip service to many of them. So thank you very much.
Could you talk, that is, first of all, thank you for the work you do, and thank you for sharing that. I think here we look at health workers as such a positive thing that happens in countries like the one where you work. And so it's a reality check to hear the realness of what happens. So how in a sort of an institutional way have you incorporated, infused hopefulness to people who are working really hard and make a huge difference in countries where it's, very necessary?
Yeah, so some of the measures that we've taken into consideration here is, one of them is providing a toll-free line. So a line where, a health worker can pick up the call and talk to someone at the other end. Most of the people on the other end are professional counselors. And this is something that was not there before. So it was just assumed that you as a health worker, since you know health, then you should be taking care of yourself. And I think that is a very, very big assumption that we need to demystify. The other thing is providing safe spaces within the facilities. So I know a couple of private health facilities that say, look, we've set aside maybe 2 weekdays to have our counselors open towards you coming in to talk and just to debrief. And the other thing that I've seen people do is have, breakout rooms that health workers can, take a break. And really taking a break is getting out from the environment, whether it is the ward or the clinic, and going to a space where they're able to unwind, or they're able to just get a different space or have a walk around the compound. So I think there's a lot more recognition or awareness about the mental health state of health workers. Unfortunately, this has been brought about by very sad incidences of murder, of suicide, of drug abuse. And for many of them, it's a bit too late to help. But now there's a lot of action, and the government has taken, consideration into deliberately looking at programs that support health workers. Yeah.
Thank you for that. That's both scary and reassuring, and reality. It's the reality. I have to excuse myself. Wendy is going to take the baton from here. Linda, you're up. I'm out. It's from Linda to Linda and Linda to Wendy. So thank you for teaching me so much in this and for this conversation. So I will pick it up for my own brain later when I watch the rest of it, but thank you for the opportunity to be here.
Thank you so much, Linda, for being here. And I know you have another exciting adventure in the next hour. So thank you. And thank you, Dr. Walla, for sharing that perspective on really what's going on at the frontline health worker perspective. And Linda, one thing that I would love to learn more about from you is from the community member who's accessing care. how do you see hopefulness and hopelessness as a barrier or a facilitator of accessing care and receiving care? And then also within this context of what we've heard from Dr. Walla, how might that relationship actually help to facilitate these barriers, or to overcoming these barriers for both parties in this relationship?
Yeah. You know, after listening to Dr. Walla, you know, there's another dynamic to this, Wendy. This, you know, we can talk about the lack of access to quality treatment, or you know, how long the journey from symptoms to diagnosis to treatment can take for Black women in the U.S. and other kinds of systemic barriers. But you know, in listening to Dr. Walla, there's another barrier, which is the burnout of healthcare providers. You know, we're talking about being hopeful, and these barriers, you know, whether it's lack of insurance or lack of a job or lack of transportation, childcare, you know, having to pay money just to go see a healthcare provider. I mean, these are barriers that keep Black women from doing what they really want to do, which is to take care of themselves. But then imagine in the midst of the racial tension, the absolute terror of COVID-19 and the abominable way, at least the last administration handled it, then you go in to see a healthcare provider who herself is overwhelmed, maybe has lost a close colleague or family member. At 700,000 deaths in this country, there's not a person in this country, it's not a Black person who hasn't lost someone close. I mean, we all know someone who has passed away. So part of the delivery of care is to deliver hope. Yes, I can help you. We can get some therapeutics or diagnostics. We can help you get better. But if, as a provider, I don't feel hopeful, it's going to be hard for me to instill that in my patients. And you know, from the perspective of the Black Women's Health Imperative, when we started as a self-care organization 38 years ago, where we, you know, the founder brought 2,000 of her closest friends together to talk about how we should take care of each other and how we should take care of ourselves and what that means for the kinds of barriers that we face. But as we know, and when I came on board almost 8 years ago, we conducted a study. Not surprisingly, stress was the #1 health issue as defined by Black women. And we've seen, you know, there's 30 years of research on the effect of racism and gender-mediated stress and what it does to our bodies, for obesity, for our inflammatory response. I mean, it leads to a whole host of adverse outcomes. But Black women were saying, you know, it's not that they don't care about breast cancer or diabetes, but they were like, if I could just have control over my life, then I could have some reason to be hopeful. If I knew that when I got up in the morning, I wasn't going to be judged because I was a Black woman. I was going to be encouraged, and nobody was going to stand in my way or second guess me or judge me. But, and I know I would have the resources to solve whatever problems occurred, fine. But unfortunately, that's not our reality. And the way society is structured sends that message. And the way media talks about Black women and their health also sends a message that it must be their fault. Something must be wrong with them. And so we've got to change our entire language as well as systems so that we can really talk about health.
I love that. It's so well said. And it also circles back to what Dr. Opara had said earlier around asset-based care and really celebrating our assets instead of pointing fingers and having this kind of a blame approach to healthcare.
Sure, because Black women don't see that there's anything wrong with them, but you would not get that impression from reading even medical literature. Yeah,
Absolutely. And one thing that really strikes me is thinking about how systems, consciously or unconsciously, can tend to pit populations against each other. And it may not be conscious, but when you think about this dynamic where you have people that are accessing care, but they don't feel heard, they don't feel recognized, they feel an implicit bias. And on the other side, you have health workers who are feeling burned out, unrecognized, as Angel mentioned. You know, that's what both parties are feeling. And one thing that we really think about a lot is when we talk about hope, we talk about it from three perspectives: individual, interpersonal, and systemic change. Because as a frontline health worker myself, if one more person tells me to just be mindful and breathe deeply, I might go crazy, or maybe I have. If there isn't also other components and other systems change involved. And I wonder what both Dr. Walla and Linda, what you think about opportunities to bring those two. How do we strengthen these relationships and really recognize there's two sides of the same coin that we could be advocating together to build that relationship?
You know, I'll jump in because I know Dr. Walla will have some thoughts, but you know, as shocking as it is to believe, the last study I read said that 30% of medical students still believe that Black people don't feel as much pain as white people, that somehow we have thicker skin. I mean, this study was done in 2019, still believe this. And so we've got this entire industry, diversity, equity, and inclusion, designed to sort of train implicit bias out of students and healthcare providers, which we know does not work, as we've seen no effect. And so I don't think we're going to train our way out of this. I don't, this cultural competency training, you don't need to know my culture to provide competent care for me. So what we're saying in this work that we're embarking on, some significant anti-racism work, is to healthcare providers, when you walk in the door, or when that patient walks in, treat that patient like they are the most beloved person in your life. Whatever you would do for that person, do for that patient. You can be a racist, you can be sexist all day long, leave it at the door. When you come in the office, you behave a certain way, like these are the most important people to you, pick it up on your way out. I really don't care. But if we could do that, then you're going to listen to your patient. When the laboring mom says, I don't feel, something is wrong, I don't feel well, you're going to then listen and follow up. When someone is not taking their medication the way you think they should, then you'll ask a question. Well, what else is happening in your life? What else, what can I do so that they can get the kind of care that they need? And then we can get to a point where we don't have 50,000 Black women dying every year in the US due to the effects of racism and gender discrimination, that alone. So then to, Dr. Opara's point, and Angel, you've got people participating in their care, which is what we talk about all the time. But if I don't feel heard, if I don't feel respected, if I don't feel valued, I can never participate in my care. And if a provider doesn't view me that way and views me as this non-compliant Black woman who's not going to follow directions, then that provider is not going to provide the kind of care that I need either.
Yeah. And again, coming back to relationships and meeting people on an individual relationship level. And I'm getting a 2-minute warning, so to go to the next panel, but I would love to just quickly hear Dr. Walla's perspective, especially in terms of when you have a health worker who's burned out. How do we redesign the system to give that person space to actually be available to their patient in that relationship way?
I think the biggest thing for me is the kind of training we receive. So our system is designed to make medicine hard, tough. Like the default is you're going to fail. So prove us that you're not going to fail. So I think that kind of I'd say barbaric kind of training inculcates a feeling that it's okay to suffer as a health worker. So I think we need to start right from the way we get people through the medical training. The other thing is to provide spaces where these people can say, it's okay, you're not a god, it's okay for you to break down, you're a human being. And I think I've seen spaces like that, like in Kenya, we have a doctors' moms group where doctors who are mothers are feeling safe to open up and say, look, my nanny did this, or my husband did this, or I'm broke, I am struggling with education and balancing motherhood. So these kind of spaces help the health worker to know it's okay to be vulnerable. I think for me, that's the first step, that we are able to say, reach out, it's fine, you're not alone, and here is help. Thank you.
Thank you. That is fantastic. And I wish we could take an hour and a half for each of this set of panelists. Everyone is so amazing. So I really want to thank you both. We're going to now transition to our third panel discussion. And this is hope in the future. And we're really, in this panel discussion, I am really honored and excited to be able to introduce you to Derek Mooneen and Catherine Getzy. Derek is the unit head of the capacity building and collaboration team of the Digital Health and Innovation Department at the World Health Organization headquarters in Geneva. He has 22 years of experience in public health informatics, digital health literacy, digital health capacity building, and project management. Derek has dual master's degrees in information systems management and in public health policy. Catherine is an entrepreneur, strategic consultant, founder, and global depression advocate. She's launched the first national cause marketing campaign for mental health through her company, The Mood Factory, and used the funding to develop Hopeful Minds, an award-winning free global program teaching the science of hope to children. And in this panel discussion, we will really talk about how do we take these concepts of hopefulness, thinking through the barriers to hope, but really focusing on hopefulness being interconnectedness, readiness for change, and a future-oriented mindset. How do we integrate these concepts into system design in a way that lasts? And so with that, I'd like to welcome you both to our panel. And so maybe to start, so thinking again, as I mentioned, how do we institutionalize this concept of hopefulness into the design and maintenance of health systems so that we can ensure long-term systems change, and instead of it kind of being a fad that hope is interesting today. And I know that Catherine has a lot of experience in actually the operationalizing hope. I think just to begin, I'll ask Derek, how do you think about, when you're thinking about digital health capacity building, for example, how do you think about the diffusion of new ideas and how hopefulness contributes to that? And how do you integrate those seemingly intangible components to capacity building into policy?
All right, thanks, Wendy, for having me here. A pleasure again to be in one of your panels, and really pleased to be, part of this esteemed set of panelists discussing very important points given the times that we're living in. We in these days are speaking about how we can actually contextualize health in the COVID age and also health in the digital age. And so this question is quite prominent given the opportunities at hand in light of the challenges that COVID has given us. We at WHO, see that for the future, the provision of health services will be influenced in one fashion or another on digital modalities. And so hence we tend to agree that the new normal is actually virtual, it's digital, it's characterized by new ideas, it's characterized by the diffusion of innovation, as you rightly pointed out. And as an organization, we just got a global strategy approved by member states in 2020 on digital health. And one of the items member states put for us in that global strategy is really thinking about four pillars of strengthening the health system, thinking about people centricity, universal health coverage, primary health care services that you talked about, but really thinking about how digitalization can enable the aspiration of universal health coverage, the sustainable development goals. And so this global strategy has many pillars, including that particular pillar. Digital literacy, national strategies, and aspects to do with partnerships. All those are, fed in that global strategy. So on the website, And I would encourage others to actually consider that. From a capacity building perspective, we have a principle in terms of making sure that innovations at least align to 3 A's and a C, which is really acceptability, affordability, and also accessibility. So they have to be accessible, they have to be affordable, and they have to be acceptable. And the C is computability. That means that as we're seeing more and more digitalization, we need to be aware that at the end of the spectrum is a person. And more often than not, we forget that the change agents are people. And so I have a spectrum of really defining our audience using what we call the 4 Ps, thinking about policymakers, thinking about planners, thinking about practitioners, the people providing services to human beings, and people themselves right in the center. And so the construct I've just labeled in terms of diffusing these ideas is critical to really consider the placement of people, because everything we do is about people, they make or break. And so in the innovation spectrum, one of the things we've been really promoting is really ensuring that we have greater awareness of what innovation can do for the betterment of health outcomes, and really thinking about putting people first. More often than not, even in my practice, we have engineered solutions and systems and telling people how it works, but really forgetting that people themselves are active participants. They make or break our innovative ideas. And we've seen good practices. In my previous life, we many years ago introduced a smart card-based system 20 years ago when mobile phones were not as popular. And we came up with this idea: how do we help moms who tend to carry books every time they have a new, every time they're expecting a baby, antenatal cards. And in Africa, as you know, each, pregnancy instance asks you to repeat and recite previous episodes. And when a person has, 5 babies, you have to really, this is an obstetric history. And so we came up with this idea of a smart card, how, really recording all the previous medical records on a smart card. And what we did then was to equate the smart card with a SIM card. So the same way we record numbers on a SIM card, the smart card is recording your medical history. Carry it whenever you go to seek care at your facility, and when you go elsewhere, carry it with you. And I witnessed firsthand a client waiting at the pharmacy and insisting the pharmacy machine had to be rebooted. And so the pharmacist was like, I've given you a medication, you're welcome to leave, we can update your records, but the patient knew that record needs to be on my smart card. And this is the role of putting people first. The patient was patient enough to wait for the machine to reboot, because the person knew, if I don't get this record here, my mates at the next point of care, I'll have an issue. So the diffusion of new ideas needs to include all the actors, especially people, to be active participants. And like you showed in your diagram at the beginning, Wendy, I think the more we have, the curve that you demonstrated in terms of the different pillars of the diffusion of new ideas, the more we have, innovators going up and early adopters, that category of people, the better we can sustain health systems. Let me pause here and give it back to you, Wendy.
Thank you. That was excellent. And I think really keep putting people first, and thinking about in the tool that we use, which is called the Health Hope Index, we've identified these 3 psychometric properties, which is interconnectedness, readiness for change, and future-oriented mindset. And putting people first actually hits on that interconnectedness, which then, and that's what I feel like is this theme across, is that putting people first builds that interconnectedness, which then facilitates hopefulness and decreases the barriers to change. And I love what you just said, building ownership. And then I also just to also acknowledge that there's more than one tool to measure hopefulness. And Catherine and her team has done a lot of work on research and actually operationalizing hopefulness among training curriculum for children and cities, which is really exciting to learn about. And they use the Snyder Hope Scale. But Catherine, maybe you can share a little bit of your background and your story as well with us.
Absolutely. And thank you so much for having me here today. It's great to be here. Yeah, I got to work around, I think it's really important to first look at hopelessness. So we were looking at creating a suicide prevention program about 9 years ago, and saw the definition around hopelessness to be a feeling of despair and a sense of helplessness. So I think it's just important to kind of look at when we create and teach a program or create a program to teach hope, how do you get out of despair? How do you proactively manage your despair to get to positive feelings? And how do you get from that helplessness to inspired action? And so that's really initially what we did with Hopeful Minds. We know that hopelessness is a consequence of discrimination and oppression, and it's growing at unprecedented levels right now. So it's great to have a panel, I think, focusing on hopelessness and hope, and really how do you operationalize hope? As you mentioned, we created a program first to teach kids 7 to 10-year-olds the how to hope. So, looking at, can you teach hope? And if you want to teach hope, how would you go about doing that? So we created a program. We use the Snyder's Hope Scale because they have a children's scale, but we used a lot of the different theorists around the science of hope and looked to actually create a program to teach it. And we did find that indeed, as you increase hope, you decrease anxiety and depression. Hopelessness is not just predictive of suicide, it's predictive of weapon carrying on school property, addiction, violence, self-harm. And so it's really important that we address hopelessness kind of on a global scale. We recently took that work, we created a SHINE acronym for hope. So looking at the 5 keys to hope, we look at stress skills. How do you identify and manage your stress response? Happiness habits, how do you create and cultivate habits that are healthy for you? We look at inspired actions. How do you take steps, set goals for your futures and take steps there? How do you create a nourishing network is the end. So how do you create connectedness that we've talked a lot about today? And then how do you eliminate thinking challenges to hope? Those patterns in your mind, like internalizing failure, negative bias, rumination, worry, some of those main things. So we created that acronym and we're now teaching it on the college campus. We created a Hopeful Mindsets program to teach, how do you learn and practice the skills for hope in college, and then recently the Hopeful Cities. So how do you operationalize it throughout a city and allow any cities kind of to do that? So we look a lot at the individual hope, and there are other people doing work in systems, which, I know with my own hopelessness, there was a lot I couldn't control. What I could control was my own ability to navigate from hopelessness to hope.
Thank you. I love that. And it's really fascinating to be able to actually take it from the seemingly intangible concept to really distilling it down and actually making it something concrete that we can focus on and tangible that we can build from. I think one other thing that comes to mind as I think about the work that you're doing, and then thinking about, Derek, as you're talking about this innovation mindset and bringing in new tools that will definitely be the way of the future. And as we've talked about earlier, having a health workforce that is feeling overwhelmed and burned out. I wonder if the how, and when we think about the implementation strategies for some of these tools, how do we encourage the implementers to think about these concepts of hope to really demonstrate that they're critical, that they're not this kind of feel good, but they're actually essential for successful implementation?
I can take that, Wendy. I can.
Sure. Yeah. Sorry, that was a big question.
Yeah. So Wendy, I think what COVID has taught us. I mean, COVID has taught us a lot of things, and building on what Catherine was talking about, we have a lot of challenges that we had never thought about before. So mental health issues, suicidal tendencies, the issues of household issues, because people are now, sort of like living more at home than at the office. And so a number of issues are surfacing. But at the same time, we have seen opportunities, and this is where the hope stream lies. And these opportunities are around the neglected, areas of digital interventions, like telemedicine, for example. Telemedicine in the past was seen as a luxury, a tool that you only use if you have no access to a better functioning health facility. And we see more and more countries now adopting telemedicine, and patient providers themselves are now able to connect to the patients no matter the location. And I think the opportunities that we now see is that we're now able to leverage this connected environment that we're now experiencing. More and more people are using virtual modalities, and so are able to build in services like telemedicine, electronic learning, and so forth. But I think what's critical really is to really build on those innovations that are approved and are adopted by the social system, the social network, okay? And really thinking about what's acceptable in a particular ecosystem. And these are some of the aspects of, innovation that we, have been promoting. Build on what works and amplify it. And I think the more we build on what is socially acceptable in a manner that is co-created, really thinking about the principles of digital development, design with the end users, and ensure that the end users' needs are put first. So we design with a purpose, and we design with those tools that are generally acceptable, those tools that are proliferated. That is a marker of success. And I would also point out that I think I broke out for a moment there because the screen froze, so it could have been on my site. And so I'll rewind a little bit. So really focusing on principles of digital development, design with the user, ensure that you are building on what are those digital tools that are socially acceptable and prevalent enough. In the field of universal health coverage, we, I believe to leave no one behind. That also means leave no one offline, okay? And really think about the marginalized, the people that have basic feature phones. And so build for, thinking about people's ability to use digital tools and what tools they have access, the tools that they're used to use. And so I gave an example of feature phones. So really, I think that the principles of integrating hope in digital systems is really felt needs of people, design with the end users, use social accepted digital modalities, use communication channels. In some instances, we fail to promote digital tools because we don't create this sufficient awareness. And so we get resistance. Sometimes health workers might feel as you automate, digitalize, you're sort of like putting them out of the care path, especially when it comes to digitalization. Artificial intelligence, for example, is a major challenge because it tends to come across to a health worker that you are replacing the health worker. But if you create enough awareness on augmented intelligence, you are sort of like able to bring about wider acceptance. The same is true with people. The more we sort of like interact with what they're used to. So everybody has a mobile phone. They're aware they can make a phone call, they can send a text. So when it comes to fighting, a misinformation, disinformation, that same mechanism is a trusted source. So these are some of the principles I could share, Wendy. I think we have more opportunities now given COVID's disruption to health that has really brought about wider digitalization. We need to be careful to ensure that we're not simply, fast-tracking digitalization without engaging the actors and creating awareness on how to use these digital services. Back to you, Wendy.
I love that. Thank you. And I think really building, just as you said, taking that strategy from a perspective of building trust, communication, engaging the most vulnerable. So thinking about how the most vulnerable people in our societies are able to access that care, that the how matters so much. And so I really appreciate that, and how the technology can bring us more closely together and build that connectedness. And I'm so sorry that we are running so behind schedule, but it's because there's so many fascinating people here to talk with. I would love to just give a few minutes to open things up to questions. I'm going to ask Kiki if she can let me know if there are any questions outstanding.
Wendy, can I just add one thing
Yes,
to
please.
the,
Yes.
I just wanted to add one thing to Derek's. One of the things I became very hopeless about is the number of providers and the number of people that need care. And one of the things we did in Hopeful Cities is we, for the first time ever for a city, got Talkspace approved. So all of a sudden had access to care for 250,000 residents, which was kind of a preventative approach during the time of COVID. And I think that's one of the great things about technology is you can get people tools that they maybe wouldn't have necessarily been able to get otherwise. And so to speak on that, I mean, it's innovation around mental health and healthcare is so important to providing access. And I think some initial results on getting the marginal communities access is really some initial results we are very promising about. We've reached a lot of those people. So it's really exciting, I think, what's coming.
Yeah, I think that's really great. One thing that I noticed as a clinician early on when we started doing more telemedicine in the pandemic, I found a higher rate of adherence and higher rate of connection because it made it easier. And then I saw a dip because then it became a phone call that was easier to kind of forget. And so I think one of the things for the future is how do we integrate the combination so that we facilitate care, make it easier, and also maintain our relationships that keep driving that cycle. I see some questions coming up, and I am pretty confident that Catherine will definitely have the answers to these because we talked about this earlier. So one question is, what health outcomes have been proven to be influenced by hopefulness or hopelessness?
Yeah, so many. You recover more quickly from diseases. You adhere to medication. You're more compliant. You live longer. So actually your lifespan, and this is a lot of this research has been used with the Snyder Hope Scale. There are some interesting things like you're more likely to graduate. You do better in school. It's more your Hope score is more predictive of your GPA than your IQ. It's also predictive of athletic performance more so than ability. So there are a lot of positive outcomes as it relates to hope.
And I can also add to that, there's actually been studies. Wendy, your face was so funny. You're like, oh, there you are. Where did she come from? If you don't mind me building on, but there's also been studies done in cancer and in chronic disease and hopefulness that actually have shown improvement in outcomes. So if you want to get even more specific. So yes, this is the real deal. It's a thing.
Thank you. And yes, you know, because I was focusing on the panelists with the cameras on, but please, everyone, feel free to jump in and join in that conversation. There is a question here about how can we inspire more frontline health workers to focus on relationships first? And I think any one of us, Derek, you might have some thoughts on this, and Dr. Walla, Dr. Opara, everyone, please feel free to share your thoughts on that.
Well, I can start as a frontline healthcare worker myself. And I think the answer is in those three wonderful words that have been mentioned over and over again. I would reframe the question as to how can we inspire healthcare workers to feel more valued, capable, and hopeful in the future. And in so doing, better equipped to then focus on relationship building. And I love the example that Angel shared earlier, where she said it was a one-on-one relationship, and she said that the patient, the woman, internalized that when she followed the recommendations of her provider, her healthcare professional, that the healthcare professional was encouraged. And then there's this sense also when I was listening to Angel about when folks feel sort of, again, encouraged, or when they are, their contributions are recognized, when they're, and the way I will frame it is in my language, Igbo, we don't have a phrase that says, I love you. Our phrase is, which means I see you. So when people feel seen, then they feel loved, or another way is to feel valued. And so, in other words, how do we create the conditions where healthcare workers feel seen is where I'm working to with that question, and therefore the solution. And so what that means then, the answer lies in systems, in my humble opinion, because healthcare workers, we want the relation. That's why we became healthcare workers, why we became physicians and nurses and public health professionals and PAs and NPs and all the whole respiratory therapists and on the whole list, right? Is that literally on my way here, I stopped by echocardiographic technician, and we're waiting for the elevator. And I smile at her and I tell her, oh my gosh, she was like, how are you? How are you? We greet each other. And I said, I'm doing great. And can I just tell you, I love my patients. They give me advice all the time. 90% is unsolicited, but it's always what I need to hear that day. And she smiles and she says, yes, that's the best part of my job. We want relationships, literally why we do this. However, where we get discouraged is when we feel unseen, when we feel unheard. So building hopeful and designing hopeful systems that see and hear us, that build into the ways that the processes, policies, practices, and the people they put in place are rooted in the respect and the dignity of all members of the ecosystem of healthcare and public health. That, I think, is where the inspiration comes in. So the reimbursement system, payment funding system, a work scheduling system, and these pieces, these systemic pieces, and the infrastructure needs to be reimagined and reconstructed in order to generate the conditions for those that live within that ecosystem of healthcare and medicine and public health to be hopeful. And that's the way that I conceptualize that.
That is so beautiful. and so well said. One thing to add to that is that one thing that was very interesting to me in all of the focus groups that Angel conducted, there was a really strong theme of recovery resources, and that it was really seen as the leadership and the system's responsibility to ensure that frontline health workers had those resources available, whether it be time, support groups. One thing that was said quite consistently was that if you have that relationship, if you do that job well and you care about that person, the weight is heavier. It's hard because you care about the outcome, you're invested.
Absolutely. You're invested. That's right.
And so how do we create that space? And I do think it's within and even across all the focus groups, it was for frontline health workers' responsibility to build the trust for the patients that are coming and engaging in care. But it's the system's responsibility to give us the opportunity to do that. That's I love it.
And I'll add that, on that point, that building hopeful systems. I mean, this is a very beautiful theme. From a digitalization perspective, Wendy, one of the items that we emphasize is really protecting patients' privacy, really the dignity, because the more we digitalize systems, the more vulnerable the data is towards abuse. And so the enabling environment for digital systems is controlled by 7 building blocks. One of the pillars in those 7 building blocks is the issue around legislation and privacy, and really those elements that ensure that both the provider and the health seeker can trust the system. And this is really the question around trust. So as a patient, I definitely would want to be put in a space where when I'm contributing my data that is being digitalized, I can trust that the data will be used for the purposes that it was provided, which is provision of care. And so from a provider's perspective, really trusting that the data is digitalized. And when I have access to this particular data, I should have access for purposes that inform the care that I'm providing. That creates a wider adoption. And again, within the division of innovation, scale is important, and making sure that sustainability is sustained. We can only do that if there's trust, there's acceptable use, and at the same time, all parties know the implications of the data that they are storing electronically.
I love that. Yes, absolutely. Trust, reliability, really thinking about these standardizations and baking it into how we think about policies and implementation. I want to thank you all so very much. And I don't know, Kiki, if there are any other questions, please let me know. I'm actually having a hard time reading the chat. But otherwise, I really want to thank you all for joining us today, for sitting in on this amazing panel of speakers. As I mentioned, we could talk to any one of you for an hour and a half and not have enough time. And so I really thank you all for joining us and wish everyone the best. And I hope we can keep this conversation going. I really look forward to continuing to work together.
Wendy, may I provide last words?
You may, absolutely.
I just really feel very strongly to, first of all, thank everyone for everything they've offered on this space. I've learned so much, but also to just offer that opportunities for hope abound all around us each and every day. I get so much hope and hopefulness from my patients, even the sickest among them. In a city like Detroit, despite the challenges that we have encountered throughout history and even currently, it's amazing the spirit of people, the ways people organize around them, each other to come up with innovative solutions to solve problems and move the city and move communities forward. So I just really want to share, young people that are thinking and challenging systems and moving things forward are ongoing, changing the medical education paradigm and ways of training healthcare workers, changing things, and so thinking beyond and outside of the box, thinking about climate change solutions and how do we do agriculture different, education different, healthcare, public health. The opportunities abound. So yes, it's tempting to be hopeless, especially in times like this. There's so much crap going on here and there. But I just want to assure and everyone, encourage folks, from yourself to the people around you, whether they're your family members, friends, roommates, what have you, and beyond, the opportunities to be hopeful abound. And so I hope that in our various spaces and spheres of influence that we are baking in and injecting little by little, but ever so surely, hopefulness. And that's how we build these systems over time. And that we challenge our representatives to do the same, our political representatives, wherever we are in the world. So I wanted to leave with those words. And again, thank you, Wendy, Tip, Derek, Catherine, Angel, Dr. Walla, Kiki, Megan, and even Linda and the two Lindas who were here earlier. Thank you again, and many blessings to you all.
What a beautiful way to sign off. Thank you. And thank you all for joining us. I'm so grateful for this event.
Thank you, everybody.
Thank you so much, everyone.
All right. Bye-bye.
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 Thank you so much.